Good morning, everyone. I'm Lori Ambrose and President and CEO of GoTo Foundation for Lung Cancer, and just so pleased to welcome all of you to the second in our series of what we've been calling rapid response webinars that have been developed in response to the questions and concerns that you have raised during the onset of COVID-19 and how it has affected implementation of screening and care in your community centers. Today's webinar examines telehealth and its use across the lung cancer continuum, from screening and shared decision-making to treatment and supportive care, and certainly exploring the opportunities, successes, limitations, but future potential as well. We will review policy and regulatory changes that have expanded telehealth options, as well as advocacy opportunities and priorities to preserve this expanded access and flexibility post-COVID-19 among payers. So joining us today are respected and committed leaders in the field who will share their knowledge and perspectives on these topical areas. Dr. Ron Myers, Professor and Director, Division of Population Science, Department of Medical Oncology at the Sidney Kimmel Cancer Center, Dr. Luis Reyes, Chief of Hematology and Oncology, Medical Director of Memorial Cancer Institute and President of Florida Society for Clinical Oncology and a member of GoTo Foundation Scientific Leadership Board, and Allison or Allie Willis, Vice President Vice President of Strategy at the Health Innovation Alliance. Of course, we invite your questions. Please submit them through our Q&A box. We'll hold them to the end of the presentations. And for those that we can't get to, of course, we will provide follow-up answers to all of the participants. So with that, I turn to Dr. Myers, who will kick off our conversation to come.
So thank you for inviting me to participate in this webinar. It's a privilege to be part of this dialogue, and I hope that the information that I share with you will be helpful as we think about how we envision addressing issues related to lung cancer screening and treatment going forward in the future. And also happy Juneteenth to everyone on the call. So I want to begin my talk by acknowledging support that we at Jefferson have received from the Bristol Myers Squibb Foundation for a project that we call Engaging a Learning Community to Increase Lung Cancer Screening in Vulnerable Populations. Some of the work that I'll be sharing with you emerges or evolves from this effort. We'll be talking about decision-making in clinical care, telemedicine, telehealth, shared decision-making, and I know many on the call know as much or more about shared decision-making than I. Shared decision-making in lung cancer screening, especially in primary care, patient outreach, and shared decision-making, a pilot study, which I'd like to share with you some of the preliminary results, and opportunities for use of telehealth in shared decision-making as we go forward. And I will acknowledge that decision-making in clinical care is a complex matter. And a decision-making is affected by a number of factors, which you can see here, that have direct or indirect effect on patients, including family and community, cultural issues related to decision-making for lung cancer screening and other things in the context of the clinical encounter, health system and environmental factors that affect both patient and clinician. And we believe, of course, that there's a lot that we can do and a lot we can learn in the physician-patient encounter, and when we observe the decision-making process, we see that they result in outcomes that are ideally and hopefully beneficial to the patient. Just briefly, the American Academy of Family Physicians talks about telemedicine and telehealth, and as we know that we have undergone a substantial change in the way healthcare is delivered, and telehealth is and will be an enduring part of the landscape going forward. As I alluded to earlier, the decision-making process in the clinical encounter is affected not just by what happens in the physician-patient encounter, but what the patient brings into that encounter and what happens after the encounter. Many reasons and many factors that patients carry with them affect what they do. And again, this is just a representation of the complexity of that process. And some of the things that we may take for granted are surfaced in the context of the encounter, but not so. Many things affect what we do as individuals and what patients do in the context of those encounters. We believe that we can make a difference, a positive difference, by increasing the likelihood that the decisions that are made are shared decisions. And we think that the decisions that are made in a shared decision-making context will be of higher quality, and will have a profound effect on screening and screening rates. The Centers for CMS, Medicare, and Medicaid have outlined several components of what they define as the ideal shared decision-making encounter: verification of patient eligibility, education, values elicitation, preference clarification through the use of a decision aid, or you will hear me referring to this as a decision support intervention that gives a balanced presentation of potential benefits and harms, counseling about abnormal results, and the follow-up and adherence to annual screening and tobacco treatment. In the 20th century and in the early 21st century, these kinds of things are intended and often do happen in an in-person encounter with physicians and patients. And we know, as I said earlier, that the transition is fully underway, so that many of these encounters are going to happen more virtually than in person. Not all, but we know that telehealth is going to become, and has already become, an increasingly important part of the encounter. The question that is important to address and acknowledge is shared decision-making about lung cancer screening, LCS, happening? And data that we know from excellent studies that have been done thus far, preliminary though they may be, a national survey suggests that only 9% of patients who are smokers have discussed lung cancer screening with a physician. In clinical practice, only half of those patients who are eligible for lung cancer screening recalled having a discussion. And when those conversations take place, they are very short and mostly focused on the benefits and not much on the harms, potential harms of screening. So, and in addition, we know that lung cancer screening rates are low, and I've given it kind of an optimistic 20% here, but statewide screening has been reported to be 16% at its best. So one of the things that we know is that we need to improve or increase the likelihood of shared decision-making and of screening. And essentially, this can be done through the use of what I would call decision support interventions, which are various categories, various types, which you see here printed online through interactive software, which are designed to help people understand what options are available, such as screening or not screening, providing information, clarifying preferences, and so on, and making sure that the choice aligns with personal values and preference, which we would define as a high quality decision. Now, again, much of this takes place within the context of the encounter, whether that's going to be a telephone or a telehealth, a video encounter, or in a person encounter. And we have taken the step at Thomas Jefferson University of trying to move the goalposts further ahead and move the ball down the field towards those goalposts by developing an online interactive shared decision-making program, which we call the Decision Counseling Program, which essentially provides the opportunity for education, values elicitation, preference clarification, and thereby shared decision-making. Now, part of this process has to do with the identification of the educational content that we want patients to know and understand. And there are a variety of sources of informational content. The GO2 Foundation has excellent materials. Elsevier, the LUCA National Training Group, AHRQ. We selected for our pilot study to use a tool called an option grid that was developed by and is now available through the EBSCO company. But it's just one of many kinds of tools that are available to provide information and education to patients about lung cancer screening. This software program that we developed, which we call the Decision Counseling Program, allows us to embed any educational materials in the program, review that material with the patient, either by telephone, by video, or in person, through whichever means of providing the information we want to use, and then move on to a process where we try to elicit values of the patient. And I won't show you all of the steps in an abbreviated presentation of this program. We essentially start the conversation by asking what things would make you favor having screening over not having screening. And a patient, this particular patient, said, well, I'm interested in having screening because I'm worried about my risk for lung cancer. Long-term smoker, I'm concerned about my risk. And by the way, my doctor suggested that I should screen. We'll shift gears then and say, okay, so what things might make you favor not having screening? And well, concerned about the accuracy of the screening test. And, I'm actually concerned about radiation exposure from the test. And then we'll essentially, allow the patient through this conversation to identify as many of these things that might influence their decision to screen or not screen as they feel important. And then focus in on the top 3 reasons that they think would motivate them to make a choice. In addition, we'll go through an exercise, a brief exercise, where we ask how important these things are and how important they are in comparison to each other. And that process, that interaction, results in a 1-page summary that indicates what the patient wants to do and why the patient wants to do that. This is a preference, a summary that for this patient indicates the patient prefers option 1 over option 2. And we present this information in this display both to the patient, and we can enter this information into the EMR for use by clinicians at the time the patient comes into the practice. Or this could be done in the practice and used in that fashion. Well, what would happen if we actually delivered this kind of outreach and via telehealth to patients who are identified by EMR to potentially eligible patients? We developed this pilot study, which essentially, as you see here, we completed with 4 primary care practices, 2,376 patients. We set aside 1,748 patients to a usual care observation group and randomized 2 other groups, a smaller group, to either receive mailed information, the educational content plus a telephone call, versus mailed information, telephone call, and during the call go through this shared decision-making exercise. And I should say that these 4 practices are part of the Jefferson Health System, and I really appreciate their engagement and participation in the project. What we have observed and our conclusions we can draw from what I've said thus far is that we know shared decision-making and lung cancer screening rates are low, especially in primary care. We know that it's feasible to deliver an outreach and shared decision-making context by mail and telephone. We didn't, in this instance, engage people in a video exercise, but that's something that we will be doing in the future. We'll actually be able to share the screens that we use to elicit patient responses with the patients in a video context. And we think that lung cancer screening rates will increase when shared decision-making is used. What we do need to know and do need to learn going forward is how we may be able to determine the impact of telephone and video and other telehealth contacts on engaging patients in shared decision-making. And we probably think, at least in the context of primary care, that the best way to do this is perhaps to work with patients who have a scheduled primary care office visit, where this outreach and contact for shared decision-making can take place prior to the visit, which takes some of the burden and load off of primary care to actually go through all of the details of shared decision-making. So I want to stop here with the final note that these methods and the approaches that I've outlined can be used and adapted for places where there is a centralized screening program or decentralized screening is offered. And the methods and the approaches here also can be used in the context of treatment decision-making. I'm not saying anything about that in the talk today, but we have done some of this work and applied the same kinds of methods to treatment shared decision-making. So I'll stop here and I'll look forward to your questions and comments at the end.
Dr. Myers, thank you so much. And yes, I know that we'll have a lot of dialogue around these issues to come. Uh, I'd love to be able to turn now to Dr. Reyes to pick up the baton and run with it for the next round of information.
Okay, so you can see my screen, I hope.
Yes.
Okay, we are going to share our experience using telehealth and oncology. As Lori said, I'm a lung cancer doctor, and I've been fighting this disease for 20 years. And I think we have learned a lot about telehealth and telemedicine lately. In our healthcare system, I work for a 2,000 doctor, 6 hospital healthcare system. We are in charge of Broward County. We're the public healthcare system of Broward County in north to Miami, Florida. As most of us in America, we have the capability of telehealth. All of us have capability of telehealth for several years, especially we have a good EMR, electronic medical record, and we have Epic. Epic is one of the most popular EMRs in America, and it's very good. However, the interesting thing is, for example, for 3 years, we have the capabilities to do telemedicine, and none of the doctors were very interested, and none of the patients were very interested. If I remember 3 or 4 years ago, if I tell a patient, hey, do you want me to see you by video? They say, no, I prefer to come in person, you know? And that was very interesting. And now suddenly, you know, telemedicine has become our main way to interact with the patients due to safety and the COVID. So I want to share a little bit about our experience on this. No, as Dr. Meyer said, the definition of telemedicine is not one. Telemedicine is very old. For example, you know, when Mr. Graham Bell invented the phone, and I think in one of the first conversations, he called a doctor because he was having a medical issue. They say that that was the first telemedicine console in the world, probably. But anyway, since the 1970s, telemedicine means really healing at distance. And in 2007, we found one of 4 definitions of telemedicine. So finally, the World Health Organization, in the last report about telemedicine, they put this definition that we have here, no? The delivery of healthcare services where distance is a critical factor by all healthcare professionals using information and communication technologies for the exchange of valid information, either for diagnosis, treatment, prevention of disease and injuries, research and evaluation, and for continuing education of the healthcare providers, all in the interest of advancing the telehealth of individuals and their communities. As you can see, it's a very, very broad definition, meaning that telemedicine can be used for everything in healthcare. I guess that's the best way that we can focus. Of course, we can find different ways. I want to give a very practical conversation because I understand this is not a scientific meeting. This is something that all of us have to win something. Really, if we focus on these 4 areas, there increase patient engagement, care in real time, reinforce healthcare techniques, and increase access to care, that will really be very successful. I don't have to praise telemedicine because either you like it or no, or we like it or no, it has become essential for all of us. But I'll only give you only one example. Why is interesting? Because it's very, for example, cost effective. You know, our cancer patients, for example, sometimes have a fever or something, and they are scared because of the chemo, and they say that we scare them, telling that if you have chemo and then you get fever, this may be some life-threatening. Sometimes they don't come to the office. Unfortunately, they go straight to the emergency room, you know, and you can see the average expenses in the emergency room. The patient has to spend 5 to 6 hours of his time, and maybe it's nothing important. It was only a fever, but the white count is fine. And you can see how come, you know, the difference between ER, urgent care, office visit, video visit, or e-visit, you know, and how the costs for the healthcare system can go down markedly if we use telemedicine. And even you can say, oh yeah, but if you do a video visit, you cannot check the blood. Yes, but the patient can go to a lab core in the corner of his house or a Quest facility and get the blood done, and then you get the results later. So that's why there are options to do these things. that can benefit the patient, save time to the patient, save time to you, and be less costly for the healthcare system. That's something that we really need because our costs are, it's amazing the number of new drugs approved for cancer and lung cancer, but the costs are going to the roof to the point that we are afraid that if the government starts to regulate heavily, it's not going to be easy for delivering cancer care. Okay, so when we talk about embracing telehealth, we used to promote telehealth before, no? Like all of these pictures I'm showing you are before the COVID. You know, we used to talk about this before. I have to sell the idea why telehealth is important. And you know, in these statistics I'm putting here, 90% of the employers are offering telehealth. The VA had a study for telehealth in cardiac outcomes, and you can see that the readmissions fell 51%. For the business people, telehealth gets a great ROI. ROI means, you know, when with the business people, that's the cost, the benefits, and the profit, and they do an ROI and a study, a business study, and then the ROI means that they get the investment is worth it because they're going to get their money back and maybe profit, no? And as we mentioned before, according to the American Telehealth Association, before the COVID, already more than one half of the US hospitals have telehealth programs. So we had the programs. The problem is we didn't use them. And some people, like the ICU people, are the ones that they start to use this. The cardiologists, the emergency room doctors, they were the only ones that probably used telemedicine before. And as you can see in the US News report that is quoted there, I already showed you in a previous picture, there is a savings for the healthcare system if we do a telemedicine visit compared if we do a in-person visit. Some practical applications of telemedicine that we have seen in these years are more or less obvious. You know? For example, for the rural populations, you know, in America, we have populations that don't have access to third care facilities, or the ones that we call four level. There is a limited access to care. So it's obvious that for them, if they want to see a highly trained specialist, maybe telemedicine is a good option so they don't have to travel. And I already mentioned how improve access, decrease costs. We are going to explain in the next slide, what it means to be synchronously or asynchronously. Asynchronously is when we are with you guys, so in the front of the patient, looking at each other in the video. But we also do telemedicine asynchronously since the internet was invented. You know, we always have friends that send us medical records and say, hey, what do you think about this patient? Give me some advice or something like that. So we don't do in real time. Or we can do a blended visit, you know, doing video in real time, but sending the records before. That also works very well because we are prepared already and we know what the patient wants to talk about, no? And as we mentioned in the bottom of the slide, as I said, cancer people and lung cancer people, we were a little bit slow because our pathologists, for example, I mentioned I have 6 hospitals. One pathologist that is an expert in brain tumors or lung tumors, they read all the slides of the other 6 hospitals without need to travel around, and that's already happening. The radiologist can read a CAT scan of the chest from one hospital without going to the other 5 hospitals, no? So that's why all of these things have been already happening. We have been the ones just coming to the game lately. And that's why if you thought that telemedicine is new, it has been around for a long time, but not really for the benefit of the cancer. Really, most of the benefits have been in the other fields that we can see here, no? I don't want to end in a negative way, so I want to mention right away what are the barriers for telemedicine so we can end in a more positive way. You know, we have an expert now that's going to talk about regulation after me. So Ali's going to talk about this. So I want to mention that before, the doctors were worried if they're going to get paid or not. So that was one of the main barriers, if I'm going to get paid. And even when Medicare said, oh yeah, we're going to pay, but you know, a lot of the insurances that we have are commercial. So, and doesn't mean that no, we're going to get reimbursed. The same with Medicaid. So that's why these were barriers that, thanks to they already, we have overcome these barriers. And also there were laws, regulations. And for example, in Florida, where I live, since 2018 already, we have state regulations that support and encourage telemedicine. So we have been very lucky. internet, even number 3, internet is a problem. You know, I don't know. My provider is terrible. They keep saying that my internet is faster and faster, and then for me it seems to be slower because more people is streaming and watching Netflix every day, and I guess that they use the band, and so that's why. But if you don't have a good internet connection, you can't do telemedicine. And the same, you know, the lack of leadership, and all of these reasons, number 5, 6, 7, the high cost of technologies. This is high cost, really. I know a lot of people are not familiar. These EMRs that the doctors use are extremely expensive. As I mentioned before, our healthcare system has here in 2,000 doctors. The EMR for us costs $100 million. So healthcare system invested 10 years ago $100 million to use this EMR that is outstanding, but that's extremely expensive EMR. I know that the previous government, I think in the Obama administration, there were some benefits for healthcare systems to participate of EMR, but that's why it's realistic that it's not easy to do this with a good EMR. And I mentioned already that we as clinicians were not engaged before. We didn't believe in the telemedicine, and we didn't know also the measures of success. You know, we thought, oh, it's probably nice to see each other over the video, but why we need that? You know, so we can see the person live. And finally, everything changed with the COVID. You know, I guess one good thing from the COVID is now that telemedicine has been promoted tremendously, and we're happy for that because we're in the future. The COVID may not go away, so we will have to have a some blending how we're going to use telemedicine or no. Okay, so for the way that we use telemedicine, as I said, there are provider to provider in red ways. I mentioned before, these 3 ways are ways that one doctor sends medical record to another, and then you answer by email. The other option is I connect with the doctor live, and the doctor explains me what's wrong with the patient, and I give him recommendations. Or we do half and a half. No, number 3. A patient comes to the emergency room and with a dermatological rash that the ER doctor doesn't know what it's about. He calls by telemedicine a dermatologist, and the dermatologist looks to the rash through the video. So there is always interaction between doctors. What has progressed tremendously is the direct-to-consumer platforms when the patient participates, and I guess number 6 is the most popular one. Yeah, because the patient also, number 4, can send me the records, and I can email him my second opinion without even talking. But number 6 is the most interesting, is the one that we're doing now. We talk to the patient live, we discuss his case, so that's probably the most important one nowadays. And this used to be before the COVID. What was the use of telemedicine in community hospitals and healthcare systems? And as you can see, a lot of psychiatry, stroke, ICU, as we mentioned before, there was not a lot of cancer there. And probably these statistics have improved tremendously after the COVID. As I mentioned before, we have 6 hospitals here in South Broward, and that's why we have to be using telemedicine for the last 3 years for many indications. But in the specific field of cancer, what we were doing before the COVID is, for example, in surgical oncology, patients that after surgery went home, they were contacted by nurse practitioners and to report how is the wound healing, what are the outcomes, any problem. And if the patient really was sick, he comes back to the hospital. If he's not sick, we can even chat every day, 15 minutes to be sure the patient is okay. The radiation oncologists, we have 6 facilities, but we don't have machines in all the facilities. So the radiation oncologists used to do telemedicine from one hospital to the other. Something important for lung cancer and the other cancer is our nurse practitioners. You know, they do triage by telemedicine. So if I go now to the clinic for 6-7 hours, I don't want to be interrupted, you know. So that's why when the patient calls, is sick, instead to wait 6-7 hours to get a call back, the nurse practitioner does a telemedicine encounter and over video. And if the patient is really sick, sends to the ER or sends the patient to our chemo unit for hydration, labs, antibiotics, etc. No, support services is something that we used to do live. Our social workers, navigators, psychologists, nutritionists, integrative medicine doctors used to meet live. But now, thanks to the COVID, really, for safety, all of these services can be provided by telemedicine. Even after the COVID, we are really thinking for the safety of our providers and the safety of the patients, all of these services can be provided by telemedicine. because all of these services don't have the need to use any infusion, any treatment, or any laboratory examination. And I already mentioned before, we have been using telemedicine in the emergency room. And I also mentioned before, because I'm running out of time, for this, when we discharge people from the hospital, that was one of the main utilization of telemedicine. Basically, I don't know, probably all of you have telemedicine, and there is more than 80 people now in this webinar. Basically, what we do is we ask the patient to sign in our EMR. So in my specific case, our EPIC calls Memorial, because my institution is Memorial Healthcare System, Memorial, my chart. Is always called chart, but with the name of your institution everywhere in America, if you have EPIC. And basically, the patient gets a link, the patient can connect with us by the internet. And the nice thing is the patient can check their labs, the CAT scan results. They can email us through this platform, not to our private email, to this platform, and we answer the emails to this platform. That also carries some legal issues, because it's something that is part of the public records now. Also now in this platform, we connect and we do the telemedicine visit. For us, it was very easy, because I said before, for 3 years, we enrolled the patients on this, and now finally we start to use it. However, also nowadays, people don't like desktops, people like the phones. So we also have an app called Memorial Doc Now. So you can connect, you can have all the benefits I mentioned in the phone with the app, my chart. But on top of that, we have an urgent care app called Memorial Doc Now. If you log to the app now, there is always a doctor on call or nurse practitioner that can answer you in real time. So you can log 24/7, and there will always be a doctor. So we can do an urgent care visit over the phone or over video, and that's even reimbursed for us. As I said, but WhatsApp, Skype, Doximity, there are other platforms that are commercial and public. The problem that we have with these platforms, patients love a lot of these platforms, is that the federal regulations didn't allow us to communicate for privacy and protected health information. So due to the COVID, now we're allowed to talk by WhatsApp, Skype, Doximity. That's something that probably can be discussed later if it's going to stay or no, because regulation, no? And finally, I'm finishing with a couple of examples about research. Something good that is happening is I live in Miami, where the red star it is, in the south of Florida, but I have a couple of patients that are in clinical trials in Hillsborough County in Tampa, and the other one is in Melbourne. And they used to drive 5 hours every month to come for a clinical trial and get the pill for lung cancer. And now we do telemedicine, and we send the medication to their home. 5 hours away, they don't have to travel, and now they do the blood in their own neighborhood clinics. And they even have a private oncology, so nobody can say that we are being relaxed with our rules. So they have a private oncologist. And the most dramatic case is in the other slide. This is South America. I have 3 people in another clinical trial. These patients are so motivated to survive that they used to fly once a month to Miami, so I can give them the medication, do blood, EKG, CAT scans. Now we do everything at home. Thanks to the regulations that have been relaxed from the IRBs and the sponsors, and we send the medications home. I don't think this can stay for a long time, but I think that can open the eyes for us that we need to be more flexible. There is one of the reasons why very few people join clinical trials is that very few people can travel and move to a place where the fancy drug is being delivered. That's why all of these have opened the eyes for us that we can really enroll more people in clinical trials if we get some relaxation of the policies that for the trials that are needed. No? For example, I'm giving you an example of a trial with a pill. If you have a trial with an infusion, of course, this is not going to work. No? And finally, there are a lot of publications about the utilization of medicine in cancer. You can review this one. We don't have time to present from the ASCO that happened 2 weeks ago. How the use of telemedicine in self-reporting symptoms may help the patients and be more efficient than to wait for a nurse to call them every 2 or 3 days and see how you're doing, okay? This study was not conclusive, but it's a good way to start. Thank you very much for the attention.
Dr. Reyes, thank you so much. And Dr. Myers, too, with your real-time clinical work and expertise and how this is really applying to this time and in the real world settings. Allie, I know it's a great transition to you to talk about these opportunities and the regulatory and policy overlay surrounding them and to come. So let me turn this to you. And then Allie, after you have finished, Anita and Angela will take over managing kind of the questions and chat to flow. So Allie, share your thoughts on this important topic.
Thank you, Lori, for that introduction, and thank you for having the Health Innovation Alliance here today. I'm going to get my slides up on screen. If everybody will just bear with me 1 minute. I have been sharing the wrong screen repeatedly, so you might see my speaker view for just a second. Okay. Is everyone able to see the slides, or are you seeing my speaker view?
You see your slides.
Great, thank you for the confirmation. So I'm going to go ahead and get started here with just a little bit of background about the Health Innovation Alliance, and then go over what we've seen on the legislative activity, regulatory activities since the beginning of the pandemic, and then what we expect, what's next. And these are high-level points, as everybody on the call knows. When you're talking about regulatory changes or compliance activities, you could spend a whole day or a whole week or a whole month talking about that. So I'm trying to just give illustrative guidance overall about what we've been seeing since the beginning of the pandemic and what we're planning for the upcoming months and for post-pandemic telehealth activity. And I look forward to everyone's questions and engagement going forward. But briefly, I just wanted to mention that the Health Innovation Alliance is a diverse coalition of patient advocates, providers, technology companies, health systems, employers, you name it, anybody in the spectrum of healthcare delivery or use who's interested in how health technology can really benefit patients and providers, increasing access and improving the quality of care. So our focus for a long time has been on telemedicine. We've been working in this industry for well over a decade. I appreciate the other speakers' background about what telemedicine is, about the history of telemedicine and how it's, sort of evolved over the years, and then where we are now. So with that, just to jump right into it, I wanted to first do an overview of high level, some of the coronavirus response packages that you may remember passing in earlier this year in March, after really we hit the height of awareness around the pandemic. And one thing that I really wanted to note about these three pieces of legislation in particular is just the sequencing. You can see that the recognition grew about the number of resources that the federal government would need to contribute to the response to the coronavirus pandemic, to support the national economy, to support public health, to really make a positive impact so that we could combat effectively against this virus. And so without going into too much detail, what you'll clearly see in coronavirus, we could sort of name these 1, 2, and 3 of the coronavirus response packages. You'll see that the first two are in the billions, which is a significant amount of money to fund public programs and responses. But on the third iteration, which is the CARES Act, which I think most people are familiar with now because it's talked about quite a bit in any sort of national news, it hit $2 trillion. It was comprehensive. It was a very long bill. It was over 1,000 pages. It included a number of authorizations. But specific to telehealth is my next slide, where you can see the comparison about the legislative changes that were implemented between these three bills. And again, without reading the slide, I know we'll share these with all of you, and I'm happy to go into detail if anybody has specific questions. I think the really important thing to note about the progression of the legislation that was adopted in response to the coronavirus is just, I refer to these as 1, 2, and 3. You have an inch, a step, and a leap in terms of flexibility when it comes to telehealth. So the first bill did include some waivers of certain telehealth requirements to create more flexibility, but still included some constraints, some loophole, or sort of some barriers that folks would have to overcome in order to really adopt and implement telemedicine. The second bill just did some cleanup items, but didn't add a lot of new things. But the third bill, the CARES Act, included an entire section dedicated to telemedicine, and then it actually modified the allowances made in the first bill to make it even more broad. I mean, that's why we say it's a leap. It really, solidified some of the changes that those of us who have been advocating for telehealth over the last decade or more have been advocating for a long time. But we've had constant barriers because there's been resistance. I know some of the other speakers mentioned, that providers and patients have really changed over the last few months in terms of an appetite or an interest in telehealth. And I think that's also reflected in the CARES Act, is that policymakers, I think because of what they were hearing and because of what they were seeing in terms of need to provide care to remote patient services, was that, this is something that we should open the doors broadly to. We should make this possible so that patients and providers can utilize remote care as needed, so that we can provide, necessary treatments for the duration of the pandemic, but while also keeping folks safe. One really important point to know about all three of these bills, and about most of the activity that's happened over the last few months that's sort of coronavirus specific, is that almost all of the activity is tied to the declaration of the public health emergency and sort of related authorizations. The important point about that is that public health emergencies only run for a duration of 90 days, and then they have to be reauthorized. And so it's very much a limited duration approval. And all of these laws and all of the activities that have really allowed for just a kind of a different world that we're functioning in terms of telehealth, are at risk. They may go away if there's not some permanent authorization, some permanent changes that allow more flexible telehealth activity that's not tied to the public health emergency or other sort of coronavirus related waivers. And that's what I wanted to talk about for the majority of the time, first I'm going to talk about the regulatory changes, and then I want to talk about what the next steps are coming out of the pandemic, what we're seeing, what we expect, and what you can do. So quickly on the regulatory side, so the first two slides I shared were focused on the legislative activity from a broad perspective, and then from a telehealth specific perspective. Well, now the regulatory activity that's pulled up kind of behind the legislative activity is coming mostly from CMS. So CMS Administrator Verma has actually kind of gone on record and said, with regards to telemedicine, her, I think, quote was, "The genie's out of the bottle," right? Like, people are getting used to this. People are now expecting to be able to connect with providers, and providers are expecting to be able to connect with patients remotely. So it's going to be difficult to roll this back. And that being said, and CMS has really aggressively rolled out regulations related to telehealth. And on the slide, you can see we divided it into multiple types of e-visits or e-encounters. But with keeping a focus on telehealth, the administration and the agency, CMS, have really been proactive and very, very favorable in their treatment of telemedicine and telehealth. And so they have taken regulatory moves, including a lot of the state waivers that we've seen that allow more flexibility for provider practice across state lines, or, allowing reimbursement for audio-only visits, certain things like that. CMS has very aggressively embraced these changes to allow greater telehealth. There is a question about how much can stick on the regulatory side once that public health emergency goes away again. As I mentioned before, if the authorizing legislation, for example, if some of these regulations are tied to one of the coronavirus response bills, so like the CARES Act, for example, the regulation may also be in jeopardy if the public health declaration goes away, because they wouldn't have the authority, they being the agency, wouldn't have the authority to allow for the permanent flexibility without legislative changes. We can talk about the details of that later. There's lots of specifics, and I'm sure all of you on the phone have legal counsel and compliance who are working through all of those details. But please let me know if I can be helpful on that. But the important thing to note here is that in addition to the changes that through rulemaking CMS has adopted, they've also made a change in their process to allow for sub-regulatory changes. And for anyone who participates in a rulemaking process in public sense, is that normally when you do rules, you have to post a rule in the Federal Register, you have to allow for comment and rulemaking, and there's a notice and comment process that you go through. With sub-regulatory guidance, there's some more flexibility on that. And it was an important note because it shows how interested CMS is in being dynamic, responsive, and open to telemedicine changes. And the idea of pushing to sub-regulatory guidance actually gives the agency a lot more capacity to sort of move on a dime if there's a change that needs to be made from a regulatory perspective. And with that, what's next? I threw out a lot of information. It's a lot to process kind of at a high level in terms of what's happening at a legislative, at the federal level. And then you layer all 50 states on top of it, and you're looking at a lot of complexity. Then we look at the fact that a lot of these changes have been made on a limited basis. There's an open question as an organization. Have you invested in changes in order to meet the demand during the coronavirus? What happens if all of these authorizations go away? And so organizations like Health Innovation Alliance and individual advocates are working directly with Congress and with the administration and with the executive agencies to look through, the next steps. What's the off-ramp? When we go to post-pandemic, when we no longer have a declared public health emergency, what does the world of telehealth, as we know it, look like? And this is, again, some of the other speakers raised this point, and I think it's very important because it informs what your practice goals are, and it also impacts your workflow. And so some of what we're arguing for, and again, we have a letter that details all of these different policies, and I'm happy to go into detail as needed, but I'm also cognizant of time and want to hear from members. Here's just a high level, our list. So the first point is permanent authorization. Without going into an abundance of detail, this is essentially asking for permanent authorization of the telehealth changes that have been made during the coronavirus pandemic that are tied to the public health emergency. Interestingly, actually this week, a number of senators on a bipartisan basis, actually 30 senators, which is a significant number of senators, co-signed a letter asking for permanent authorization of telehealth flexibilities. And we also heard 2 days ago, in a committee hearing, Senator Alexander also went on record saying this is something that we just need to do. We've seen the benefits of telemedicine. It's allowed us to step forward. This is just, we have to figure out how to make this pathway work. Yes, it's expensive. And yes, it's something that we didn't think we were going to do this quickly, but here we are now. So let's make sure that we don't go back. Some of these other details in here, and again, I won't go over all of them in detail today, but open invitation for anybody who would like to know more about any of the specifics I've listed here. Another one I wanted to highlight is occupational licensure reform. And so for all of the providers who are on the phone, you of course are familiar with the licensure regulations that are managed at a state level. Well, 2 weeks ago, the administration released a deregulatory order where they're really looking at different opportunities to create more flexibility on a lot of different things, but including occupational licensure. This has been a longstanding debate. Of course, due to states' rights and state jurisdiction, it's not something that the federal government is in a position, unless they were going to preempt states, which would be a whole nother battle, that they can do directly. So they're encouraging states to look at more reforms on occupational licensure for all different provider types. And I just wanted to make note of that because this is probably a debate that all of you on the phone have heard before about, is it really important that I get licensed in Florida and Georgia and Carolina, in order to practice in those areas? And historically, the answer has always been yes, with some exceptions, but now the conversation is changing. And this is in part due to some of the flexibilities that have been allowed in response to the coronavirus. And again, you can see the list here, but I did want to note the last point about the 90 plus bills reaching telehealth in this Congress. That's the 2019-2020 Congress, the current Congress. I've worked with my team at Health Innovation Alliance to start doing a complete environmental scan, a landscape scan of legislation to see what are all of the bills that were introduced prior to the pandemic, as well as during the pandemic, that reached telemedicine. And there's just an overwhelming amount of interest in changing the guidelines that pertain to the practice of telehealth in Medicare and in other areas as well. And so we're continuing to advocate for basically any reform that will bolster telemedicine, because we think it's critically important in terms of creating access and allowing more flexibilities for patients and providers, and will really benefit all of us who intersect with the healthcare system. And so, again, I invite questions. I want to stop there to leave a few minutes for folks to engage with all of the speakers. And again, thank you so much to the GoTo Foundation for Lung Cancer for hosting this webinar, for inviting us, and for being members of the Health Innovation Alliance.
Okay, I think we're going to transition now to Q&A, and Anita has been monitoring the questions.
Yes, I have been, and we've been responding to a number of them as we've been going throughout the presentations, but I'm going to kind of run through a couple of them because a few of these are really important to the screening community as well, and questions around shared decision making. And I'm going to flip to one of them. Okay, so one of the questions came in from Teresa regarding lung screening shared decision-making consult, and whether an organization or if an organization implements an interactive shared decision-making patient education video into a patient portal, and at the end of the video offers the patient an opportunity to connect with the physician or provider with questions and concerns answered, but via a call back again from the provider. Is this an accepted method by CMS to implement or to meet that shared decision-making consultation? She added, I introduced this concept in an effort to serve rural populations across the US, given 90% of the US is rural, with only 4% of the eligible patients being screened for lung cancer. I answered the question, but if anybody on the panel wants to chime in, feel free to.
Anita, what was your answer, Anita?
So in looking at CMS's the telehealth approved services list, it was a number of years ago, they did add G0296, which is the shared decision making code for lung cancer screening consultation. And so that's been on there for a number of years. However, they recently, under the public health emergency, are allowing the service to be met by phone. And so if you look on their approved list, they've added a column, and in that column it says allowed by phone. And so this is a particular code that's checked on that column. So it can be currently met by phone, but in the past it had to be bimodal. So again, Allie's made a good point about the public health emergency and how that that clock on the public health emergency will end at the 90-day term and has to be reauthorized. So it is important that we continue to advocate that some of these broadened telehealth regulatory changes will remain. So we hope that that will remain.
Anita, I think this is very important because for example, when the primary care doctor orders a lung screening, it's not a big deal. You already have a decision with a visit with the primary care. The problem is if a patient, for example, is looking at one of your programs and he's a smoker, more than 55-year-old, and he qualifies and he wants to have the screening, the problem is now that we need to have a visit before the screening. So the patient cannot get even a prescription from me without seeing him and doing the visit. So that's I think is a limitation that we have. That's what I hope that this emergency mandate prolongs, because that's one of the barriers that we have for the screening, I think.
I also just quickly wanted to mention, so currently it was the public health emergency was authorized for the first time on a retroactive basis into late January, was reauthorized, I believe, in late April. So the current expiration date is in late July. And we've been in contact with the administration. They do still say that they're evaluating. We expect, for many of political and policy reasons, that they will extend. I would be very surprised if the public health emergency is removed prior to the election. But we will see, and we continue to advocate. I also wanted to, kind of put an open invitation. Obviously we work directly with the foundation, but with any members as well that have specific interests, we do a rolling list, and we continue to reach out both to congressional members as well as administration officials to highlight key areas that are tied to some of these authorizations, including some of the codes or additional changes that need to be made, because there are certain barriers that they may not be aware of. So I just wanted to give that open invitation to everyone to continue to engage with us and with the foundation.
Thanks, Allie. That's so important. And I think your coalition comment letter is super helpful, and we'll share that more broadly too. Another question that came in is, and actually, Ron, did you have anything to add regarding shared decision making?
No, your response is consistent with my understanding as well.
Great. Another question, Allie, and I think this is probably for you, had to do with the codes for virtual check-ins. This was listed, I think, in your slide where you went over the 3 methods of yeah, so telehealth, virtual check-ins, and then the e-visits. The ones I had indicated had to do with G2010 and G2012, but just wanted to confirm that with you.
I will give the honest answer. That is, I have to look that up. I don't have the codes memorized. I'm not that good, but I still have to look them up, but we can confirm offline.
Great. And we have a couple open questions, so I'm going to run through these two. So, and I'm just going to read them. One came in from Joy. It says, we have defined pulmonary providers that complete shared decision-making visits prior to lung cancer screening CTs, after receiving referrals from providers secondary to VPA and EPIC. I think this might go to either Ron or to Dr. Reyes.
So I can begin. I'm not sure if I completely understand the question, but
yeah, can you repeat?
There are centralized screening programs and there are decentralized programs, and a care provider who would be ordering the low-dose CT scan can order that CT scan, and after the shared decision-making process has taken place, either completed by the provider, him or herself, or if that is completed in a shared decision in a central screening program, a designated provider can also complete the shared decision making and order the CT scan or the low-dose CT scan. So I'm not sure if that fully answers the question, but that's my impression.
Joy, feel free to chime in if you want to clarify, but great response, Ron. And Therese, I'm going to move on to Teresa's question. Telegenetics has often lagged behind the medical visits. With the shortage of genetic counselors across the nation, is there a promise of that being offered for reimbursement?
So telegenetics is very important, and it's an important policy issue area. I can tell you from Health Innovation Alliance, just a quick note, our organization, Horizon, which runs Health Innovation Alliance, runs 6 other coalitions as well, including a couple that are specific to gene therapies and genetics. And so there's some crossover, and I would invite additional conversation with that to go through the details, because it's one of those issue areas where, you know, groups are getting together and advocating. It's so important to make sure that your message is heard and that you're communicating directly with officials or policymakers. Oftentimes it's not that they don't have an interest, it's that they just don't know if they don't know about the specifics. So Again, open invitation to everyone. If you don't connect directly or haven't connected directly historically with policymakers, please let me know. I'm happy to help facilitate that. Or I know you can work with Anita and Angela and the team because they're very involved with us. But, it's one that I haven't heard a lot about. So I do think that it is important to get on record to talk about it. That's not to say that conversations aren't being had. It's just to say that on a lot of the sign-on letters and, it's kind of like more global perspectives, that's not an area that's been specifically called out on a frequent basis.
Thank you, Allie. And we had one question that I'm going to go over, and then we're going to come to a close. Jody Steinhardt had asked about their process. It says, we have lung cancer screening alert in our EMR. In order for the requisition to go through, the physician must click that the patient has been counseled and the harms and benefits of lung cancer screening. However, many of the patients don't know why they're getting screened, why they're getting the scan. Sounds like 8 out of 10 at their site believe it's because of a cough. So how can they ensure that physicians are actually doing the counseling and not just checking the box? Dr. Reyes, do you want to take that? I know that you had typed up an answer.
Yeah, I think maybe the doctors are too busy, sometimes don't explain very well to the patients, but as we have been mentioning, there has to be a shared decision-making visit or encounter or now hopefully a phone call between the patient and the provider. And as much as I understand, I think the nurse practitioner is allowed to be part of this. Doesn't have to be the doctor. And but that is a limitation because ideally, in the ideal world, all of our primary care providers are supposed to be ordering these long screenings as they order the mammograms. But because it's not happening, a lot of times are the patients themselves that are requesting the screenings. And that at that moment, we need to get them to have this encounter, to have the visit with the nurse practitioner or with the doctor, so they can have the screening where they can sign the consent. Also, it's important they sign the consent because also they need to be incorporated to our screening programs. And a lot of times there are healthcare systems like mine that they are open. So we work for the government, but we also allow private people to come. So we need to consent them so we can follow them because the patient may be coming from a private doctor and we don't want to impose on him the need to follow if the patient doesn't want it. So that's why the patient needs to understand there needs to be a visit so we can discuss briefly all of these issues. And you're right, education is very important.
I think we'll close there, and I'm going to pass the baton over to Angela. Thank you so much, Dr. Reyes. Great response.
So thank you so much. I hope that everyone can see my concluding screens here. Let me just say it has been such a pleasure to host today's webinar, and we are extremely grateful to Drs. Myers, Reyes, and to Allison Wills and Health Innovation Alliance for being so generous with their time and expertise. Today's webinar was recorded, so we'll share a link to the recording and to the slides with everyone very soon. And I just want to point out some of these resources I know you all are familiar with. We have many resources that we hope can make your hard work a little easier. We aim to be the go-to for the O2 that gives you more breathing room in your own work. So on our website, you can find a range of patient education resources available to you. We have our patient education video that explains the purpose, process, risks, and benefits of lung cancer screening with the intent to encourage and prepare screening eligible patients for informed dialogue and shared decision-making. It is now also available with Spanish or simple Chinese subtitles. And we have a screening education brochure that can be used either along with the video or as a standalone. And it can be downloaded from our website or ordered in limited hard copies for free. And it too is available in either Spanish or simple Chinese translation. We have a wide range of other patient education materials, from a comprehensive patient handbook to numerous brochures, one-pagers, and fact sheets on topics that span the care continuum. And you can find these on the For Professionals tab of our website. Our Lung Cancer Living Room Patient Education and Support Series is traditionally hosted both in person and via live stream each month. Now, it has recently become a bi-weekly rapid response virtual gathering that's focused on the needs of lung cancer patients and their families and caregivers during the COVID-19 pandemic. Just this past Tuesday's Living Room had a presentation by Dr. Kyle Hogarth with the University of Chicago, focused on managing multiple lung nodules. You can view recordings of all of the sessions on GoTo Foundation's Facebook page or YouTube channel, linked on our website through the Resources and Support tab. Tomorrow is our GoTo Summer Jam Virtual 5K Your Way, and any and all of you are welcome to join the broadcast of our opening ceremony tomorrow morning. It'll be live streamed on our YouTube channel at 9 a.m. Pacific and noon Eastern, and you can see the link there. For any of you also who are familiar with our annual Screening and Care conferences or our Care Continuum Centers of Excellence Summits, this year we're going to be bringing these two events together for a Centers of Excellence virtual summit. We are adapting our plans to the age of COVID-19, so stay tuned for more information on this year's virtual event taking place at the end of October. And last but not least, I am thrilled to announce that just this week, GoTo Foundation and the Department of Veterans Affairs formally announced a partnership, allowing us to offer the VA educational and technical assistance and to collaborate on ways to improve veterans' access to high-quality screening and care within the communities where they live. Together, we're helping break down barriers to save lives. You will be hearing more about this from us soon as we reach out through the Screening Centers of Excellence and the Care Continuum Centers of Excellence for vital knowledge and resource sharing. You will soon receive from me a very brief evaluation survey via email. Please do take a couple of minutes to complete it and share some feedback to guide our future efforts. It's really short, only like maybe 5 questions. As always, you can reach out to us anytime at screening@gotofoundation.org. Moving too fast. And before we go, I want to extend our sincere thanks to our sponsors, AstraZeneca, Bristol-Myers Squibb, Bristol-Myers Squibb Foundation, Genentech, Lilly Oncology, Pfizer, and Takeda. With that, we will bring today's webinar to a close. Be well, everyone. We look forward to seeing you again soon. Thank you.